Hello, welcome to Pathagonia. This is Jay. Today we're going to talk about in situ lesions of the breast from Kurt's notes, prepared by Dr. Kurt Schaberg. Please visit his website if you already haven't. It's such a great resource for pathology residents. So let's talk about normal anatomy first. Histologically, the breast can be divided into these units called terminal duct lobular units, TDLUs, and they are increasingly small branching ducts, as we can see here, that terminate in clusters of acini called lobules. So here is an acini, which I think of like grapes, and this is a lobule. So milk flow is, first the milk is secreted by the acini, and then they get excreted into the ducts, to the collecting ducts, and ultimately to the nipple. And it's set in fibrostroma with varying amounts of adipose tissue. There are two cell layers. There's the inner epithelial cells right here within the acini. There are cuboidal to columnar cells with eosinophilic cytoplasm and oval nuclei. And it stains with low molecular weight cytokeratins like CK7. And sometimes they're hard to see, but you have an outer myoepithelial cell layer. They're flat, sometimes barely visible to plump, with abundant clear cytoplasm. You can stain with actin, calponin, SMMHC, P63, CK56, and S100. Now that we talked about normal anatomy, let's talk about in situ lesions. First, usual ductal hyperplasia, or UDH. These are benign epithelial proliferations that architecturally, cytologically, and molecularly heterogeneous. As Dr. Schaberg says, think polyclonal, which means they'll look somewhat different. They won't look exclusively like one type of cell. They'll have cohesive proliferations with haphazard architecture. There's irregular slit-like lumina, as you can see here. Often peripherally located, they have this streaming syncytial pattern. There's variably sized cells with indistinct borders. There's overlapping nuclei, and they have nuclear grooves, as you can see here, and sometimes pseudo-inclusions. Any bridges are thin and stretched. Any micropapillae have broad bases and narrow tips with small pyknotic nuclei. The cells stain with a mixture of low molecular weight cytokeratins like CK7 and high molecular with CKs like CK56. And because it's polyclonal, there's heterogeneous ER staining. If it were monoclonal, it'd be kind of a very strong ER staining. And with UDH, there's a 2 times relative risk of developing cancer, and the treatment is there are none needed. So let's compare UDH with low-grade ductal carcinoma in situ, or DCIS. UDH, think polyclonal. Low-grade DCIS is monoclonal. UDH will be irregular, slit-like lumina, often peripheral. Low-grade DCIS will be regular, punched out, cookie-cutter lumina, often central. UDH has streaming architecture, minimal polarization, and low-grade DCIS has prominent polarization. UDH, there's variation because this is polyclonal in cell size and shape. Low-grade DCIS will be monomorphic cells and shape. The cell margins will be indistinct, whereas in low-grade DCIS, there will be distinct cell margins. UDH, there will be admixture of cell types, epithelial, myoepithelial, and or apocrine, and they stain with high and low molecular weight cytokeratins, and there's heterogeneous ER staining. In low-grade DCIS, there's proliferating cells that are epithelial. Myoepithelial cells are against the basement membrane, and epithelium stains with low molecular weight cytokeratins only, and there's a strong diffuse ER staining. So let's see here, you have the CK56, there's kind of patchy staining here, whereas in low-grade DCIS, there's no staining. ER in UDH is patchy, whereas in low-grade DCIS, there's strong diffuse ER staining. Now that we talked about UDH, let's talk about DCIS, or ductal carcinoma in situ. This is a non-invasive neoplastic epithelial proliferation. often detected on mammography with linear calcifications, and often limited to one duct system, but can involve lobules, called cancerization of the lobules, and or can skip around in the duct. And DCIS, you can have low grade, intermediate grade, or high grade. And this is based on nuclear morphology, but can be varying grades within one case due to tumor heterogeneity. The grade is not architecturally based. So let's begin with low-grade DCIS. Think monoclonal. They're small monomorphic cells, uniform size and shape, regular chromatin with small nucleoli. They're 1.5 to 2 times the size of a red blood cell, as we can see here. And there are few mitoses. The architecture often cribriform or micropapillary growth, often forms microrosettes or glands with polarization around the gland, and sometimes they can have solid growth. Calcifications are common, however, necrosis is uncommon, and the size requirement is greater than 2 millimeters and involving more than 2 complete spaces. Before we get on to intermediate grade, let's talk about high grade DCIS. Think ugly, pleomorphic. These are large, ugly cells. I mean, look at this maybe this is a lymphocyte, and compare it to these cells. These cells are very large. They're irregular, they have coarse chromatin, they have prominent nucleoli, as you can see here, and they're often 2.5 to 3 times the size of a red blood cell. And there's lots of mites. Architecturally, they'll have solid architecture, minimal to no polarization. Cometonecrosis is common, and sometimes there's single layer of cells, clinging carcinoma. And it's uncommonly cribriform or micropapillary compared to low-grade DCIS, and there is no size requirement. Now that we talked about high-grade DCIS and low-grade, let's talk about intermediate-grade DCIS. As you would expect, it's in between the low and high grade. There's moderate variability, size, and polarization. It may have necrosis and or calcifications. And DCIS, there's 10 times the relative risk of cancer in the same side of the breast. And treatment is excision with wide negative margins, plus or minus radiation and or hormone therapy. Now, let's review and compare low-grade DCIS with high-grade DCIS. Low-grade DCIS has small monomorphic cells, 1.5 to 2 times the size of red blood cells, regular nuclear contours, even chromatin, inconspicuous nucleoli. As Dr. Schaberg says, monomorphic, think monomorphic. High-grade DCIS, think large, pleomorphic, ugly. They're greater than 2.5 to 3 times the size of the red blood cells. There's irregular nuclear contours. There's coarse chromatin. There's prominent nucleoli. Architecturally, low-grade DCIS is cribriform or micropapillary, and high-grade DCIS is usually solid growth, but any architecture can be present. Low-grade DCIS, there is polarization around lumina. High-grade does not have polarization around lumina. Necrosis is uncommon in low-grade DCIS, whereas it is common in high-grade. It must be greater than 2 millimeters, although in high-grade DCIS, there is no size requirement. Low-grade DCIS, ER and PR are often positive, whereas in high-grade DCIS, ER and PR are more frequently negative. HER2 is generally negative in low-grade DCIS and positive in high-grade DCIS. There are few mites in low-grade DCIS, whereas there's many mites in high-grade. And low-grade DCIS is, as you might expect, has low-grade associated cancers, whereas high-grade DCIS has high-grade associated cancers. Now that we talked about UDH, DCIS, low-grade, intermediate grade, high-grade, let's talk about this entity called atypical ductal hyperplasia, ADH. It is a non-invasive neoplastic epithelial proliferation resembling DCIS in that there's similar cytology and architecture, but it's less developed in architecture, size, or extent. It's similar genetically to low-grade DCIS, clonally related, just smaller or questionable architecture. The size criteria for ADH is less than or equal to 2 millimeters and less than 2 duct spaces. The cells look the same as low-grade DCIS in that they're monomorphic. They can have small nucleoli. They have round nuclei with dense chromatin. The architecture is cribriform, rigid bridges, as you can see here, and bulbous micropapillae, as you can see here. And if you have ADH, you have generally a 4 to 5 times increased relative risk of breast cancer. And if we found this on a biopsy, the treatment would be surgical excision to exclude any underlying DCIS or carcinoma. If we see this on an excision, nothing more to do. So let's talk about the stepwise diagnosis. You get a breast biopsy. You evaluate the cytology. Is it high grade or intermediate grade? If it is high grade or intermediate grade, consider intermediate or high grade DCIS and its mimics. If you're unsure, consider UDH versus intermediate grade DCIS. And how do you distinguish that? You can use CK56 and ER stains. Remember, UDH is polyclonal, so it'll have a mosaic pattern. CK56 will be patchy, and there will be patchy ER staining, and that supports UDH, which is non-neoplastic. Whereas if there's negative CK56 and uniform, diffuse, strong ER staining, that supports a neoplastic process like intermediate grade DCIS. If the cytology does not suggest high grade or intermediate grade, then if the cytology is low grade, bland, you want to ask, is the cytology monotonous, clonal appearing? If it's not, then is it polymorphous, polyclonal appearing? Then you want to evaluate the architecture. If you're unsure if the cytology is clonal, you also want to evaluate the architecture. And if it is monotonous and clonal appearing, you still want to evaluate the architecture. And then, are there neoplastic architectural features present? If yes, and the cytology is polyclonal, then consider UDH versus ADH. If you're unsure if the cytology is clonal, evaluate the extent. If less than 2 millimeters, consider ADH. If 2 to 3 millimeters and non-uniform, consider a borderline lesion like ADH versus DCIS, or consider low-grade DCIS. And if greater than 3 millimeters and uniform throughout lesion, consider low-grade DCIS. And the same thing you would do if the neoplastic architectures are present and it does appear monotonous. You want to evaluate the size. If you're unsure if there are neoplastic architectural features present, if the cytology is polyclonal, think UDH. If you're unsure if cytology is clonal, think UDH versus ADH. And if you're unsure of the architectural features and the cytology is monotonous and there's solid or subtle architecture, consider ADH or ALH, which is atypical lobular hyperplasia, or LCIS. Or if it's a flat process, consider FEA, which is flat epithelial atypia. We talked about DCIS, but we haven't talked about LCIS, which is lobular carcinoma in situ. Some ways to distinguish is LCIS, there will be a loss of cohesion. DCIS will be more cohesive. LCIS will more often than not have intracytoplasmic vacuoles, whereas DCIS has less amounts of intracytoplasmic vacuoles. LCIS has a tendency to have pagetoid ductal involvement. DCIS will be less common. LCIS will often have absent microacini, whereas DCIS will have microacini. And polarization at the duct periphery, LCIS won't have that, whereas DCIS will oftentimes have that. Now that we talked about DCIS, UDH, let's talk about, we also talked about ADH. Let's talk about columnar cell change. What is this? So these are clonal alterations of the terminal duct lobular units characterized by enlarged, variably dilated acini, as we can see here, lined by columnar epithelial cells arranged perpendicularly to the basement membrane, which is right here. And they're 1 to 2 cells thick. They have these apical snouts, and secretions and calcifications are often present. This is the earliest step in low-grade carcinoma pathway. It's not infrequently associated with ADH, low-grade DCIS, or invasive carcinoma, but the risk of developing a subsequent carcinoma is negligible, so excision is not indicated. So you might have columnar cell change, but if there's more than 2 cell layers thick, we can call it columnar cell hyperplasia. And if there's more complex architecture, you should consider atypical ductal hyperplasia, ADH. We briefly mentioned in the flowchart FEA, or flat epithelial atypia. These are similar to columnar cell change in dilated TDLUs, but lined by 1 to 2 layers of cells with enlarged round to oval nuclei. It's the same cells that you might expect as an ADH or low-grade DCIS. The complex architecture of the type seen in ADH, low-grade DCIS is not allowed, such as bridging or the bulbous micropapillae. Apical snouts, secretions, and calcifications may be present and frequently associated with DCIS cancer. So if found on core biopsy, it is an indication for excision to exclude a worse lesion nearby. No further treatment is required if you find FEA on excision. Let's talk about radial scars / complex sclerosing lesions. These are benign lesions with fibroelastosis and entrapped glandular structures, as you can see here, with plus or minus proliferative epithelial lesions like UDH. What's the difference between a radial scar and a complex sclerosing lesion? Radial scar is smaller with stellate configuration, whereas a complex sclerosing lesion is larger and more disorganized. Look for a dense, hyalinized elastotic stroma. 2 cell layers are maintained, the epithelial and outer myoepithelial layers. And excision is somewhat controversial, but oftentimes it's excised. And you may want to do a myoepithelial stains to confirm that no invasive component is present, given the architectural complexity. Let's talk about lobular neoplasia in situ. These are epithelial proliferations also originating in the terminal duct lobular units, characterized by small, discohesive, monomorphic cells. It's driven by an E-cadherin inactivation. So if you do an E-cad stain, there's oftentimes a loss of membranous E-cad staining and leading to cellular discohesion. Up to 15% of lobular lesions retain E-cad, but with an aberrant staining pattern. And there's a CDH1 mutations are common, which is the same gene as hereditary diffuse gastric cancer that leads to the kind of signet ring or poorly cohesive carcinoma. Lobular neoplasia in situ can be divided into ALH, which is the ductal equivalent of ADH. So atypical lobular hyperplasia is a solid proliferation of discohesive monomorphic epithelial cells, expanding less than 50% of the acini in the terminal duct lobular units. If incidental on a biopsy, there is no need to excise. And lobular carcinoma in situ, greater than 50% of the acini are filled and expanded, as you can see here, and here, and here. Often greater than 8 cells thick, non-obligate precursor to invasive lobular carcinoma. And there's an 8 to 10 times relative risk of cancer. And if incidental on a biopsy, no need to excise. On excision, if you see LCIS, margins don't matter. And LCIS, there are different subtypes. There's pleomorphic LCIS, as you see here. and it's composed of large cells greater than 4 times the size of a lymphocyte. As you can see here, this little lymphocyte is 4 of these can fit in here, with marked nuclear pleomorphism. There's also florid LCIS. These are classic LCIS cells, but forming a confluent mass-like lesion with little to no intervening stroma between distended terminal duct lobular units, often approximately 50 cells in diameter. Both of these subtypes exhibit greater genomic instability, meaning that they can behave more aggressively and you would want to excise with negative margins. So, some IHC stains that can help differentiate normal epithelium from lobular neoplasia from DCIS include ECAD, ECADherine. The normal epithelium will be membrane staining, lobular neoplasia will oftentimes be negative, and DCIS will have membrane staining. You can also do P120 catenin. Normal epithelium and DCIS will be membrane staining, but lobular neoplasia will be cytoplasmic. And then you could do beta catenin. The normal epithelium and DCIS will be membrane staining, but lobular neoplasia will be absence of membrane staining. So let's talk about other entities. We talked about UDH, ADH, DCIS, ALH, LCIS, columnar cell change, FVA. Now let's talk about sclerosing adenosis. This is very common. It's a lobulocentric proliferation of acini and tubules accompanied by compressing fibrosis, as you can see here. Epithelial cells are often cuboidal, small and bland. Myoepithelial cells have spindled hyperchromatic nuclei and inconspicuous to prominent clear cytoplasm, and can highlight myoeps with IHC stains if necessary, because sometimes these are tricky because of the angulation and because it might be hard to see myoepithelial cells. This can mimic cancer. Microcalcifications are common and can extend into fat occasionally and can be involved by epithelial proliferations like usual ductal hyperplasia. Primarily significant as it can be, as mentioned before, confused with carcinoma. Let's talk about lactating adenoma. These are benign breast nodules diagnosed during pregnancy or breastfeeding that is composed of an aggregate of glands with lactational change, as you can see here. These are well-circumscribed proliferations of closely packed hyperplastic secretory lobules separated by delicate connective tissue. They're often cuboidal to hobnailed epithelial cells, and they're bland with vacuolated to granular cytoplasm and small uniform pinpoint nuclei. They spontaneously regress when you're done with lactation. What about microglandular adenosis? These are haphazard proliferations of small, round, uniform tubular glands composed of a single layer of epithelium without associated myoepithelial cells. So these are an exception where if you don't have myoepithelial cells, it's not cancer. But oftentimes in other cases, when there are no myoepithelial cells, carcinomas, for instance, won't have myoepithelial cells. So this is just one exception. The luminal spaces are open and often contain an eosinophilic colloid-like secretion. There's small, bland nuclei with amphiphilic cytoplasm. So the cells stain with cytokeratins and S100. They're negative for ER, PR, and HER2, and as mentioned before, myoepithelial stains are negative. They're benign, but thought to be a non-obligate precursor to basal-type breast cancer. And your differentials include sclerosing adenosis. However, S100 will be negative and myoeps will be intact. And tubular carcinoma. However, these will be ER positive and S100 negative. Let's talk about tubular adenomas. These are benign, usually in younger women, and it's uncommon. They're well circumscribed, sharply demarcated, dense proliferations of closely approximated round to oval tubular structures with little background stroma. The glands have the usual 2 layers of epithelium and myoepithelium, and may be related to fibroadenomas histogenetically, but just the stroma is poor. Apicrine adenosis think of it as apicrine metaplasia and sclerosing adenosis. This is a lobulocentric proliferation of benign glandular structures composed of cells with abundant granular cytoplasm distorted by fibrosis. They're enlarged round nuclei with prominent nucleoli and often have apical snouts, intact myoepithelial cells, and you can, if you're unsure, you can highlight with IHC. Cells typically are ER negative and androgen receptor positive, and positive for GCDFP15. If there's significant cytologic atypia, it's defined by greater than 3:1 size variation and mitotic activity, consider the diagnosis of atypical apicrine adenosis. If there's complex architecture like cribriform growth or very marked pleomorphism, consider apicrine DCIS. Collagenous spherulosis. These are intraductal deposits of basement membranes. They appear as hyaline acellular eosinophilic spherules or fibropapillary amorphous eosinophilic to mucoid material. The myoepithelial cells surround the lumina and are often compressed and spindle-shaped. They can be calcified, commonly seen with papillomas, usual ductal hyperplasia, or sclerosing lesions. The main importance is to recognize that it is benign and not ductal carcinoma in situ or adenoid cystic carcinoma. So we are almost there. Thank you for watching this video and learning alongside with me. Last entity is Gynecomastia. These are bilateral, diffuse, or discrete retroareolar masses, the most common lesion of the male breast. And these are caused by androgen-estrogen imbalance. It's normal in infants, children, and adolescents. In a minority, often older age, it is pathologic and associated with endocrine abnormalities like Klinefelter syndrome, obesity, cirrhosis, and certain drugs like spironolactone and marijuana. The histologic appearances varies with duration and stage. The early is loose periductal stroma with mixed chronic inflammatory infiltrate. There's extensive epithelial hyperplasia with tapering tufts, kind of like a pyramid-shaped micropapillae, and protrusion into the lumen, like what is seen in juvenile fibroadenomas. So have a high threshold for calling DCIS and ADH. And then the late stage is fibrosis and hyalinization of periductal stroma. There's atrophy of the epithelium, and you can see pseudoangiomatous stromal hyperplasia, or PASH, as you can see here. And gynecomastia is not associated with any risk of cancer, so usually no treatment is necessary. So just lastly, the male breast histology contains fibrous stroma and branching ducts and terminal ductules, but extremely few, if any, acinine. This is why males generally tend to get ductal carcinoma, but not lobular carcinoma. Thank you for watching this video of in situ breast lesions. We talked about normal anatomy with the TDLUs, and the cells can be divided into inner epithelial and outer myoepithelial cells. If you don't have myoepithelial cells, then that suggests a carcinoma, or you can have the accession of microglandular adenosis. We talked about in situ lesions, including usual ductal hyperplasia. Think polyclonal. They'll have a patchy CK56 and heterogeneous ER staining pattern. We talked about DCIS. It's based, you can subclassify it as low grade, intermediate grade, and high grade based on nuclear morphology. Excuse me. We talked about atypical ductal hyperplasia. The criteria is the size has to be less than or equal to 2 millimeters and less than 2 duct spaces. We talked about columnar cell change, which oftentimes has the apical snouts. And if it's more than 2 cell layers thick, it'll be columnar cell hyperplasia. We talked about flat epithelial atypia, which has the cytology of low-grade DCIS/ADH without the architecture of those entities. We talked about radial scars and complex sclerosing lesions with fibroelastotic stroma and entrapped glandular structures. We talked about lobular neoplasia in situ. Often it's driven by an ECAD inactivation from a CDH1 mutation. You can have atypical lobular hyperplasia. This is due to the cells expanding less than 50% of the acini, and LCIS, which is greater than 50% of the acini are filled and expanded. These cells, LCIS, ALH, are very discohesive. And then if you have LCIS, you can have a pleomorphic florid subtypes. And in these entities, negative margins do matter. We talked about sclerosing adenosis. These are compressed acini due to the background fibrosis, and it can mimic carcinoma. We talked about lactating adenoma will have lactational changes and will resolve spontaneously after breastfeeding. We talked about microglandular adenosis, where the myoeps are absent, but these are S100 positive. They stain with CK cytokeratins, and they're negative for ER, PR, HER2. We talked about tubular adenoma, which is like a fibroadenoma, but just kind of the stroma is poor. We talked about apocrine adenosis. This is apocrine metaplasia and sclerosing adenosis. We talked about collagenous spherulosis, which has prominent deposits of basement membrane. And we talked about gynecomastia. All right, well, thank you so much for listening. If you like this, give it a thumbs up, subscribe, and tune in for the next episode of Pathagonia. Bye.